Hi friends, today we'll discuss something related to the workup of infertility. So as I told in previous class, if it's a case of infertility, then workup is for both male as well as female. Okay, male I will discuss in another video. Basically you do semen analysis first. Okay, and hormone profile. All this LHFSH, but this is something which you do it. Okay, so female is something which I will discuss now. So basically before that you should know what are the classification. Anat approach, anat physiopatho, I think we discussed in our last class as well. So according to that you might have ovarian cause. Okay, let me draw it for you so big that you won't forget. Okay, ovarian cause, tubal cause, uterine cause. Correct. First let me talk about ovarian cause. So according to WHO, they again classify it as 1, 2, 3. I don't know whether it's a competency or what. So here, one is if it's low. What? LHFSH. If it's low, then most likely it's a Kalman syndrome. Okay, treatment is pulsatile GnRH. If it's low, next what? It should be normal. Correct. Then you need to think something related to that anovulatory cycle or PCOS, all those things. Or if FSH, FSH is low and estrogen levels are even less. Okay, yeah, I'm talking about FSH and estrogen, not LH. Okay, then POI, primary ovarian insufficiency or early menopause. Okay, I will come to the investigation part. It's very beautiful. Please stay throughout the video. Okay, now coming to your tubal things. Okay, so you can either have a proximal block, intermediate block, or mid segment is what we call, or a distal block. Correct. No, again in distal they say you have mild, moderate, severe. It's super specialty level. Let us not learn about this. In tubal causes, remember your TB is the most common cause, almost 10 to 15% is because of that. Then again PID, all this chlamydia, gonorrhea, all those things. In any previous cases of septic abortions, all those things comes here. Then your uterine cause, again you will have uterine, semi. Yes, you can either have anatomical causes, pathological causes. In anatomical, all this septate, didelphys, all those things you need to know. In pathological, you have to think about Asherman syndrome, okay, any fibroids, all those things. That is what I would like to think about. And again, you can also have all this cervical cause, which comes under unexplained. That 10% also causes this cervical cervicitis or any anti-sperm antibodies which are present. Okay, all those things also comes under this. Okay, this is the basic thing which you should know. So now coming to the investigation workup. No? So basically, you need to think about this, think about this, think about this, and think about this. This release like so basic investigations which you will order is semi for tubal patency. What do you need to check? You do a hysterosalpingography. Correct. So for your uterine, if it's an anatomical problem, then you will do an ultrasound abdomen. Than abdomen, I would say pelvis, or a transvaginal scan. Got it. So this is the basic workup which you should know, and also about hormones, because based on FSH and estrogen is something which you do, and also you do progesterone levels. When do you do? At day 22. Why? It has a reason. Okay. So this is the basic investigations which you need to do in case of a female. Now if you find any pathology in HSD, something related to tubal, think related to that. If you find something related to moth eaten appearance, think about Ashirman. If you see features of septate. If you see features of didelphus. Okay. Then if it's something to do with hormones, then most likely ovarian. See how beautifully investigations are tailored based on the anatomical problems. I mean pathological problems. You got my point. So this is what I want you to know. Okay. Now again, the treatment is based on your pathology, right? That I think I explained in the previous class itself. Correct. No? So basically, I want you to know that tubal causes are most, and also you should know when you do this hysterosalpingography, 2 to 5 days after menses, and it's a painful procedure. So you should know what are the things you should do. It is usually you should give NSAIDs 30 to 60 minutes before the procedure. Okay. And also if you suspect any if it's a high risk case, then you give doxy for 5 days. Okay. Then you should know what are the contraindications, because this is something which is important. So I am discussing contraindication can be active bleeding or PID, because you are spilling it to peritoneum, so she can have peritonitis. Okay. Then what is the contrast used? Urographin. Okay. Then why, how it is used, what is Leach Wilkinson cannula. Okay. Then what do you see, what are the appearance which you can see. Okay. All those things is very important. Now after doing all these things, if you don't find anything, then you do laparoscopic chrome approbation. So basically you see it can be both diagnostic and therapeutic. So if you are seeing any problems, then something related to you, and if there are any mild adhesion, you can treat it there itself. No, so that is one thing which you should know. Okay. And so what color do you use? There you use methylene blue. Okay. So that is one thing which you should know. And also basic investigations is something which I taught about. Then also here, if you are suspecting something to ovarian or POI or early menopause, then you need to also think about doing an ovarian reserve test. How do you do? You can basically you test for both FSH and estrogen levels. Also you can do something called as I forgot it. Is it AMH? Can you just let me know? I'm not sure about this. Okay, you do something else also, so that is increased. So basically, if SH is increased and estrogen is less, most likely it's POI. Then you need to do the ovarian reserve test. Okay. Yeah, it's AMH, correct, anti-Mullerian hormone. I'm sorry. Yeah. So that if it's increased, then most likely that it is ovarian reserves are less. So that is the basic management which you should know to treat a particular for infertility related to women. So women, as such, this much should be enough. And also in history, you need to ask a proper history about what is the duration of infertility, what is the coital frequency, whether she has any sexual dysfunction, and also any menstrual related problems. So the basic approach which I had, the history, examination, investigation, treatment. So investigations I taught, examination nothing much. Okay. But history is what I'm speaking now, that duration and all. So that thing you should have a very good idea. Okay. Then also you should ask about any any antipsychotic drugs. Okay. Antipsychotic drugs are known to cause increased prolactin, and also that does D2 blockers. Yeah. Infertility. Okay. Then any family history or thyroid is something which you should look into. Okay. Coming to examination part as such, especially you need to look for endocrine, because that is a first starter approach. No, all endocrine related things you should rule out. Then you need to check for any tenderness, organomegaly, fibroid, all those things. Then also you have to check about in post speculum examination. You need to check about cervix and vagina, how it is, all those things. Then basic investigations I thought about. So female infertility as such is so much. In this video we discussed about the workup in case of female. In subsequent class we will also discuss about how to go about in male, and what approach you should follow there also. So basic approach is one for tubal, one for uterine, one for ovarian. Then if it's coming abnormal, in screening itself, localized towards that particular aspect. If not, then again At the end, you do laparoscopic chroma perturbation, so that you know what is the actual pathology. Then you classify it and treat the pathology accordingly. Make sure you follow this approach. Okay, male infertility we'll discuss in next class. Okay, that's it for today. Thank you.